afternoon, friends. I have been entrusted the task of discussing the MIS options in osteoporotic fractures. We are all aware that percutaneous vertebroplasty was developed to stabilize the fractured osteoporotic vertebrae and can be performed under local anesthesia with negligible blood loss. It provides immediate vertebral stability and weight bearing and can be performed very well as a day-care surgery and is quite cost effective. However, the downsides of PVP are that there is a significant amount of recurrence or persistence of pain, and there is also a bone loss around the cement in the long term. The liquid monomer tends to cause sudden hypotension in many patients, whereas the liquid cement does have a tendency to extravasate into the vein, the lungs, and more so recently from within the heart as well. Any posterior migration of cement, as shown here, can lead to a disaster and requires an immediate open surgery for the treatment. The kyphoplasty was developed to increase the safety of the procedure of the cement injection. It requires insertion of a balloon to create a cavity within the vertebrae, and the thick paste like the cement is then inserted in a controlled manner. There is minimal extravasation of the cement with reduced embolism and cement related complications. However, the disadvantages of percutaneous kyphoplasty are that it leads to an increased stiffness of the vertebrae, higher chances of adjacent segment fractures, as well as greater chances of a recompression fracture, and it is not cost effective. This article, published in 2018, where the authors reviewed 281 patients of compression fractures, showed that a third of their patients developed recompression fractures. What they showed was that the greater contact of the PMMA with the central end plate reduced the chances of recompression. Subsequently, patients with neurological deficit were treated with hybrid constructs, where the vertebroplasty and the kyphoplasty was done in conjunction with fixation. And the favorable results in these patients allowed the extrapolation of this concept to vertebral compression fractures. These are the images of a 68-year-old male who presented to me with persistent back pain following a fall. And if you notice, he has a pincer variety of a fracture with superior and inferior end plate fractures. I decided to go ahead with a hybrid fixation, and over 4 years, he stood the test of time, although there was some degree of collapse which was visible. Cemented augmented screws, also called fenestrated, was subsequently developed because they demonstrated increased pull-out strength as compared to the regular pedicle screws. The fenestrations were located in the anterior third of the screw. It allowed filling of the anterior and middle third of the vertebrae without risk of cement extravasation. And less than 2 ml of cement per injection was recommended, and less so even for the upper thoracic spine. So subsequent cases were done with fenestrated screws as is shown here. Although this was an open case, we decided to do a percutaneous prophylactic vertebroplasty above the fixation. The same concept was then extrapolated again as an MIS fashion in this individual who was quite elderly and having an ankylosed spine with a compression fracture at D10, which was going in for a non-union. No amount of general anesthesia was absolutely impossible because of medical comorbidities, and we decided to do everything percutaneous under local anesthesia, and this was the result that we were able to get. Certain novel implantation techniques have been developed for the same concept, and what was known as vertebral body stenting was developed, and vertebral stents were then inserted, expanded, and filled with cement. However, the RCT that was done along with kyphoplasty showed that there were greater implant-related complications, and so currently they are being used only in neoplastic patients only. The Kiva implant was developed in 2010, which is basically a coiled peak implant deployed over a guide wire, and the cement insertion allows integration of the implant to the vertebral bone. It was noted that it was quite effective and provided a better correction of the wedge deformity with the Kiva implant. A spine jack implant was also developed subsequently, which allows correction in chronic cases. And in an RCT, it showed that there was better correction being maintained with the spine jack. However, another article noted that there was a higher incidence of adjacent segment fractures and a prophylactic vertebroplasty above the spine jack was recommended. An osteofix cementless system was shown to be inserted percutaneously without cement, where expandable titanium mesh cages were inserted. And because cement was not used, there were no cement related problems, no leaks, no adjacent fractures, and there was a reduced radiation exposure to the surgeon and staff. So if we take home the message that despite novel innovations, cement augmentation of OVCF has stood the test of time. Despite the allegations of being a sham procedure, VP and KP are here to stay. Hybrid procedures tend to provide better relief as compared to isolated VP or KP in select situations, and we need to better define the indications of using these implants in conjunction with VP or KP. MI's options exist, but they need to be more cost effective, and teriparatide has proven to be a